Welcome back to your Pediatric Dentistry channel Tiny Teeth Talks. If you are new to this channel, subscribe the channel, and for details of this channel visit the bio section, or you can also check out my first video. Sorry if there is any mistakes in videos or shorts. Today we will cover the fourth part, which is radiation protection in pediatric dentistry, and a small topic, behavioral consideration in pediatric radiography. First, you should know the basic principles of radiation protection. So there are three basic principles of radiation protection. The first is the justification. One should only expose the patient after a thorough clinical examination and anamnesis. Anamnesis means it's a patient's account for their medical history with past illness, treatments and other health details. Means the information one gathers with the taking radiograph will have a substantial impact on diagnosis, treatment and outcome. In pediatric dentistry, if the patients cannot cope with the procedure and the quality of radiograph would not be diagnostic, the exposure should not take place. The second is the limitations. One should always try to keep the dose as low as possible without compromising the image quality and the diagnostic yield. And these can achieve under the principle of ALARA, which is as low as reasonably achievable, then ALADA, which is as low as diagnostically acceptable, ALADA IP means as low as diagnostically acceptable, indication oriented and patient specific, which is recently added. The third one is the optimization. One should always try to obtain the best image quality possible, however, with both previous principles in the mind. Rigid rules have been replaced with the philosophy of radiation protection called the concept as low as reasonably achievable, ALARA, and the other two, which is ALADA and ALADA IP. Basically, ALADA means one of minimum exposure without specifying a specific dose or a level of exposure to radiation unacceptable or deemed potentially harmful. There are many effective methods of minimizing exposure to the patients and the dental office personnel. So first one is the prescribing needed dental radiograph. A dentist should have a professional judgment about the number, type and frequency of dental radiograph as per the recommended guidelines, and these guidelines apply the principle of ALARA, meaning using the least amount of radiation possible without defining a specific unsafe dose. This is the AAPD guidelines for prescribing the radiography, very important for pursuing MDS. In and out question usually asked to PGs. I will link the PDF in the prescription, so one should know and follow this guideline. Then the second is the proper equipment. The dental X-ray tube head must be equipped with the appropriate aluminum filters, lead collimator and position indicating device, and no leakage should be present. So starting with the aluminum filter. The purpose of aluminum filter in the X-ray tube head is absorb long wavelength, poorly penetrating X-ray that are not useful in producing the radiographic image, thus reducing this somatic exposure by as much as 57%. So basically, aluminum remove the weak X-ray that don't help create the image, which reduce the necessary radiation exposure by up to 57%. Coming to the lead collimation, a collimator is a lead plate. This is a lead plate with a hole in the middle, and it fitted directly over the opening of the machine housing where the X-ray beam exists. The tube head collimation is used to restrict the size and the shape of the X-ray beam and reduce the patient exposure. Rectangular collimation result in a reduction up to 70% of the radiation exposure and absorbed dose, but rectangular collimator is underutilized in practice. Coming to the position indicating device or the position indicating cone. It appears as an extension of the X-ray tube used to direct the X-ray beam. Three types of position indicating device are conical, rectangular and the circular or the round. All these types are further available in a long and short type, and the former being more useful, which is the conical, as it causes the less divergence of the X-rays, and rectangular cone irradiates 80 to 85% less tissue than the short circular cones. Coming to the thyroid collar, it is a flexible lead shield that is placed securely around the patient's neck to protect the thyroid gland from the scattered radiation. The use of thyroid collar is recommended for all intraoral films. It reduces the thyroid gland exposure of primary beam by 50%. This is the thyroid collar. Coming to the lead apron, so it is a flexible shield that is placed over the patient's or radiographer's chest and lap to protect the reproductive and blood forming tissues from scattered radiation from reaching these radiosensitive organ. It is recommended for all intraoral extraoral films, reduce cathode radiation to 98% and minimize exposure to chest, pelvis, long bones where major portion of the hemopoietic system are located. So these are for radiographers and these are for the patients. Coming to the fast film, it is the single most effective method of reducing exposure to X radiation. E speed is twice as fast as D speed film and requires only one half of the exposure. Film holding devices. It helps to stabilize the film position in the mouth and therefore the patient's finger is not exposed to the unnecessary radiation. Coming to the proper film handling. It is required to produce a diagnostic radiograph and to limit the patient's exposure to radiation. So handling X-ray film correctly ensure clear images and reduce the patient's radiation exposure both. Coming to the correct film processing procedure. It significantly improve the quality of radiograph. Following factors are important to assure the quality of radiograph. For example, dark room free from the light leaks, adequate dark room safe light and time temperature processing. Coming to the operator protection guideline. This guideline used to provide the basic safety information that is needed when working with X radiation. Operator protection guideline include the recommendation on distance, position and shielding. The first one is the dental radiographer must avoid the primary beam. Stay 6 feet away from the X-ray tube during X-ray procedure. Protective barriers like apron and film holder should be used. To avoid the primary beam, the dental radiographer must be positioned at 90 to 135 angle of the beam. The dental radiographer must never hold a film in a place for a patient during X-ray exposure. Never hold a tube head during X-ray exposure. Should stand behind the protective barrier like LED screens. X-ray machine should be monitored for leakage radiation. Amount of X radiation that reaches the body of the dental radiograph can be monitored by using a personal monitoring device known as a film badge. This should be worn at waist level. After the dental radiographer has worn the film badge for a specific time interval, it has to be returned to the service company for the dosage calculation. In dental radiography, the main concern arises from the saliva contamination of work areas and equipment, so therefore there is a radiographic infection control. We should know that which are the common conditions that can spread due to the inadequate radiographic infection control. So first one is the infective hepatitis caused by the hepatitis B and C, HIV disease and AIDS caused by HIV, cold sores caused by herpes simplex virus, rubella, tuberculosis, syphilis, diphtheria, mumps, influenza. Now there are suitable precautions for prevention and spread of any disease. The first one is training of staff in infection control procedure. You have to train your staff. All clinical staff should be vaccinated. Open wound on hands should be covered with the waterproof dressing. Latex gloves should be worn for all radiographic procedure, but eye safety protection and mask are not usually necessary. Gloved hands should be washed under the running water. Before and after x-raying every patient, use disinfectant such as a providine iodine 7.5%, surgical scrub which is betadine, or chlorhexidine 4%. All required film packets and holders should be placed on disposable trays to avoid contamination of work surfaces. To prevent salivary contamination of film packets, they can be placed in a small barrier envelopes before use, and after use the film packets can be emptied out of the barriers envelope into a clean surface, then handled safely. Film packets must only be introduced into the daylight loading processors using clean hands and wash gloves. All film holders or the bite blocks or the bite patches should rinse after the use and then autoclaved or discarded if disposable. X-ray equipment including tube head, control panel, time switch and cassettes which have been touched should be wiped after each patient with the surface disinfectant like sodium hypochlorite, quaternary ammonium aldehyde or peroxidase. A radiographic appointment may be a source of anxiety or discomfort for the young patients. A balance should be established by pedodontic radiographs between the child inner resources and the demands of the appointment, and we have to follow the basic principles of ALARA, and for that only one good quality radiograph should be taken. So there are the steps or instruction for the successful radiograph in the young child. The first one is the reduce source of unnecessary anxiety. Motivate the child to do his best to cooperate, so there will be a good image quality radiograph can generate. Use minimum number of film and in as short time as possible. The communicating principle of tell, show, do and modeling are effective in radiographic appointment to reduce the anxiety and prepare the child. At the first appointment, the interview may be more personal and less intimidating by giving an invitation to come in a while we take a picture of your teeth. The decision to invite parents depends upon the assessment of the child patient. So in first appointment, interview should be familiar, and if only you think the parents need, then only ask them to come with you and the child. The radiographer introduced the protective lid apron as a blanket and X-ray unit as a camera. It is also helpful to demonstrate the clicking and buzzing sound associated with an exposure before filming begins. In the next visit, procedure of biting on the film packets must be modeled by the parent or dental assistant or a child of a similar age group. It is sometimes wise to bring the X-ray tube into the contact with your own face to dispel any fears a child may have. A good idea is to have the X-ray tube set at the needed angulation and placed next to the child face just prior to the insertion of the film. Allow the patient to inspect and touch the film packet before it is placed in the mouth. If the child has a tendency to reject the film, then dampen the film packet. Such dampening take away taste of the packet. Do not insert the packet indirectly, but place the film in a horizontal plane and then gently rotate into the vertical position. Before inverting the film, curve it slightly so as not to impinge on a lingual tissue, and the film should not be forced into the floor of the mouth. To ensure an initial success, the easiest area are radiograph, which is first anterior films, and for posterior projection, some form of film holding device is recommended. The observation of other children getting exposed for the radiograph reduce the anxiety and increase the cooperation in a young patients. Imitations or modeling, as it is called, is most effective when the model performs successfully and is reinforced for his behavior. Movements must be minimized and the child should be asked to focus on a wall object so his eyes do not follow the operator when he leaves the room. Once the film is placed, the dentist slowly counts to 10, and in the meantime the operator completes his cone positioning moves to his safe position and expose the film. If the patient is very uncooperative, it is also advisable to take the radiograph while the patient is seated in the parent's lap. There are some radiographic recommendations for the children with the disabilities. So only radiographic investigations appropriate to the limitations imposed by the patient's age, cooperation or disability should be attempted. Means when performing radiograph investigation on a disabled child, only the necessary and appropriate imaging technique should be used considering the child's age, ability to cooperate and any disabilities they may have, and the goal is to minimize discomfort and ensure the child's safety while still obtaining the needed diagnostic information. Select intraoral film of appropriate size, modifying standard techniques as necessary. Utilize assistant to help hold the film. Avoid dental panoramic radiography because the patient will have to sit for the 18 or 15 seconds. Oblique lateral radiograph should be regarded as the extraoral view of the choice, and use of paralleling technique if possible for periapical radiography, because with this technique the relative position of the film packet, teeth and X-ray beam are maintained irrespective of the position of the patient's head. It is important to realize that taking the radiograph often is a part of the child's first experience, which must be pleasant experience so as to make him a good dental patient. Stay tuned for the next part, and it is very important that you know everything till now. So if you still don't watch my all 4 parts related to radiography in pediatric dentistry, the link is here. Go watch and follow for the next part, which is digital radiography. If you want this PDF or any other PDF, just like, subscribe and comment your mail ID with the topic. I'll send you the PDF. New videos on Thursday evening 6 p.m. and Sunday morning 11 a.m. Also, we try to put MCQs according to the topics on our shorts with the answers and explanation if needed, which will help you in Viva or NEET exam. Like, share and subscribe the channel. Thank you.